Hello everyone, welcome to our second fracture conference. Today our topic of discussion will be a midshaft or diaphyseal humerus fracture. Our patient is a 30-year-old right-hand dominant male who was struck by a motor vehicle as a pedestrian. He fell down onto his left side. Presented to the emergency department and was evaluated. He was found to have a radial nerve palsy at the time of his initial evaluation, but otherwise neuro intact and no other injuries. Here are his initial radiographs, and you can see that he has a transverse with butterfly fragment midshaft humerus fracture. There's a little bit of comminution of his butterfly fragment. Let's talk a little bit about the anatomy of the humerus. The humerus is largely surrounded by muscle. It's one of the reasons why the humerus has such excellent healing rates with non-operative management. I've already mentioned it so far, but one very important anatomical structure to remember when we're discussing humerus fractures is the radial nerve. Of course, the radial nerve comes off the posterior cord of the brachial plexus and then courses its way along the posterior humerus in the spiral groove and then exits out laterally before it goes more distal. This is one of the reasons why the radial nerve is so often affected by humerus fractures. Another important anatomy topic to discuss when you're thinking about humerus fractures would be the joints above and the joints below. When you add up the shoulder joint and all of its particular ranges of motion with elevation, abduction, and rotation, with the elbow joint and its motion as well as the motion of the forearm, there's actually a lot of tolerance for displacement or angular deformities in the humerus. So this is another reason why humerus fractures can so successfully be treated without operative management. Up to 20 degrees of anterior angulation and up to 30 degrees of varus or valgus angulation can be tolerated and still cause or still allow for a very functional upper extremity. So all of this extremes of motion, especially at the shoulder joint, really allow for some wider tolerances in terms of non-perfect union. So let's talk about the treatment options for this particular patient. We discussed options with him when he presented in the emergency department and talked about potential surgery for this particular injury versus an attempt at non-operative management of his fracture. One thing I will note about the patient, and this is something that is important to consider when you're treating patients with humerus fractures and considering non-operative management, would be their overall body habitus. This particular patient is not morbidly obese by any stretch, but he is a big guy. He's muscular. He's 314 pounds. Sort of a barrel-chested type gentleman. This is important to consider when attempting to brace or splint these particular injuries. So in talking with his patient and giving him options, he elected to trial a non-operative course of treatment. So we put him into a functional brace or a Sarmiento brace in the emergency department, as well as a brace for his hand and wrist, and then instructed him to follow up in a week. So when he presents to the office in a week, you can see his follow-up radiographs here. In terms of varus valgus or anterior-posterior angulation, this fracture is actually within good tolerances. However, the large distraction at the fracture itself here is what I would say is the most concerning part of these radiographs. Certainly we're far outside of the jumping distance of osteoblasts and the potential for healing of his fracture. So we had a long conversation with him about that. We talked to him about options. We talked to him about the potential for soft tissues being stuck in his fracture site, and maybe this is why he had such a large gap there. And ultimately, the patient elected to undergo operative treatment of his fracture. I want to talk a little bit more about the operative and non-operative, or the indications for operative or versus non-operative treatment of humerus fractures. I mentioned earlier that without surgery and bracing, we can experience up to 90% healing of humerus fractures. So certainly not every patient requires a surgery with a diaphyseal humerus fracture like this. Remember, radial nerve palsy is not an indication to consider surgery. The majority of radial nerve palsies can be observed and will return with time. I'm going to link a couple papers down below that discuss radial nerve palsy in the setting of humerus fractures and the outline for management and observation of these injuries. What are the absolute indications for operative treatment of a humerus fracture? An open fracture is an indication. A brachial nerve palsy, a brachial plexus palsy is an indication for treatment of humerus fractures. Polytrauma patients are mostly an indication. They're not an absolute indication, but certainly polytrauma is an important thing to consider in patients that have humerus fractures to help them with mobility and ambulation. Other absolute indications for fixation of a humeral shaft fracture includes a vascular injury that's going to get repair. If you have a floating elbow injury, then fixation of the humerus is important as well. I think ultimately one of the most important things to consider when it comes to treating humerus fractures is having a conversation with the patient. Every patient has a different tolerance for operative versus non-operative management. Every patient has a different set of risk factors that would make you potentially lean more towards considering surgery in conversation with them, or perhaps never considering surgery in a conversation with a patient if their risk factors are too high. So while there are certainly textbook indications versus contraindications, there's always the importance of discussing with the patient, giving them the options, explaining the risks and benefits of a surgery to them, and then making a decision with the patient as to what would be the best course of treatment. So with this particular patient, we discussed the findings on the radiographs. He was having continued pain, and I was ultimately concerned that we weren't going to be successful with a non-operative treatment of his fracture. So we decided together that operative management of his fracture would be appropriate. When it comes to operative treatment of humerus fractures, you have a lot of options for how you can access the fracture. Certainly several options for fixation of the fracture. And a lot of times patient factors will come into play with how you might choose to do a particular surgery for any given humerus fracture. So I mentioned that this patient was a pedestrian struck by a motor vehicle and that he fell down onto his left upper extremity, and he actually scraped up the anterior lateral aspect of his arm and had some significant abrasions there. They're healing, but I was still a little bit concerned about the skin. And the reason I bring that up is because when we're thinking about approaches for fixation of a humerus fracture, if we're considering plate fixation, which is what I was considering for this particular patient, your two best options are either an anterior lateral approach or a straight posterior approach. Because of skin, I actually elected to go with a posterior approach for this particular patient. I also wanted to be able to fully explore his radial nerve if we were going to be doing a surgery with that relatively big fracture gap. Now, I certainly have done anterolateral approaches in patients who have radial nerve palsies, and if you dissect appropriately, you can see the radial nerve through an anterolateral approach. Given the soft tissues, I elected to go with a posterior approach for this particular patient. So when we're thinking about setting up the operating room, I prefer to do this with the patient in a lateral position in a beanbag. And then I utilize a metal post that has a padded holder for the arm to appropriately position the arm. This just gets connected to the bed, and the arm can rest in this post. We're able to provide a little traction on the arm in order to get clear of the metal and get good x-rays in the operating room to make sure we have appropriate fixation. So this is my preferred method. There are lots of other things. There are some commercially available positioners that you can utilize. So lots of different options for getting good positioning and radiographs of these particular injuries in the operating room. When you're doing a posterior approach to the humerus, you can treat the triceps in a couple of ways. Most commonly, you can either split the triceps, so you just dissect straight down through the triceps, or you can also do tricep sparing approaches where you dissect off one side or the other. Of course, you have to remember that you have the radial nerve on one side and the ulnar nerve on the other side when you're doing these tricep sparing approaches. And if you're doing a tricep splitting approach, the radial nerve is right in the middle of the muscle there. In this particular setting, if I'm doing a revision surgery or if I am doing a surgery where I want to really get a good look at the radial nerve, then I choose the tricep splitting approach to really be able to dissect out and get a good look at the nerve. So for fixation of this particular patient, we positioned him lateral with his left arm up, and elected to go with the tricep splitting approach. So a straight incision on the midline of the posterior arm. You dissect down, and then you find the triceps fascia and open the triceps fascia, and then you can bluntly dissect through the muscle posteriorly until you start to get up to the region around where the radial nerve should sit. I'm going to provide a link to a Yellow Journal article, that's the JAOS, or the Journal of the American Academy of Orthopedic Surgeons, that shows the anatomy and exposures of the humerus. This is one of my favorite articles when it comes to talking about humerus fractures, because it really does a complete job of showing all the different exposures to the humerus and outlining the anatomy, especially the nerve anatomy. So when you're looking for the radial nerve, from the joint to about 10 centimeters, you're very safe to split the triceps. And then once you get to about that 10 centimeter mark, that's about where the radial nerve will exit the spiral groove on the lateral aspect of the humerus. So that can be a good lighthouse to you for where you should start looking for the radial nerve. You can also use the posterior cutaneous nerve of the arm to help lead you to the radial nerve, and that can also be another way for you to help. So once you start dissecting up there, as you get about 10 centimeters, you need to start looking for the nerve and being very careful. It's very close to the it's very close to the humerus, right on top of the bone. So you really have to dissect down through the muscle and locate the nerve. It's always accompanied by a couple of veins, the vena comitatus. So that is another way to help you identify the nerve. If I'm using this approach in a non-union or revision type scenario where there's a lot of scar tissue, there are nerve stimulators that you can use to help locate the nerve tissue if it's encased in an area of scar. This is a way that you can utilize and find the radial nerve and protect it. After I've dissected out the nerve, I just place a vessel loop around it so that I can gently retract the nerve one way or the other to get access to the bone. In this particular patient, as we dissected down, it did appear that the soft tissues surrounding the nerve and perhaps a small portion of the nerve were entrapped in the fracture site. We were able to free all of this and look at the nerve proximally and distally, and it was actually completely intact, and there were no other issues with the nerve. But this is one reason why there was very likely that large distraction of this particular patient's fracture. He had just gotten some soft tissues stuck down into the fracture site. So after you've identified the nerve on the medial and lateral aspects of the arm, you can again dissect up through the musculature to get to the proximal humerus, and you can actually get a relatively full exposure of the humeral shaft with this approach. If you need to get into the head of the humerus or down further than the olecranon fossa, you're really not going to have a lot of success with the shaft itself, and maybe consider another approach. But you can get onto the more metaphyseal bone distally if necessary. You just have to dissect down a little bit further and may need to get into the triceps tendon a little bit. So those are all things to consider. So once we're down and have the nerve protected and the fracture exposed, for this particular patient, you can see he had that butterfly piece. We were able to reduce the butterfly piece and put in a lag screw. We used a 3.5 millimeter screw to get lag fixation. This allows us to turn that 3-piece fracture into a 2-piece fracture, and then we have a good surface that we can compress against. So we're utilizing our plate as our compression agent. I'll show some pictures of the what we call LCDCP plates. Our particular plates are made by Synthes, although a lot of different companies have this sort of design to allow for compression of plates, compression of fractures utilizing the plate. So there are scalloped holes in the plate, and if you drill a hole on the very far end of the plate opposite the fracture, as you screw that screw into the bone and the screw head comes in contact with the plate, it'll actually pull the opposite fracture fragment towards you to compress the fracture. So you're engaging the head of the screw. As that happens, the opposite fracture fragment is being pulled towards you, and you're compressing the fragment. You can do this multiple times, and this is a really cool technique with more transverse type fractures that can accept compression. One thing that's important to remember when you're doing this is you actually have to over contour the plate just a little bit. So you have to put a bend in the plate so that it looks bent upwards with the fracture, the surface of the bone underneath you. So you have a little bend up with the surface of the bone underneath you. And what that'll do is that'll allow equal compression across both sides of the fracture. So the near cortex, or the cortex that the bone is sitting on, will compress, but also the far cortex, the opposite side of the bone, will compress as well, and you'll get equal compression across both sides. And actually, as we're looking at our fluoro images of this particular patient, which I have up on the screen here, you can see we potentially didn't contour our plate enough, and there might be a slight gap on the opposite surface of our fracture. I still think that we're together enough that it won't cause a healing issue, but we could have probably bent this plate just a little bit more to get a more equal compression on both sides of the bone. So when it comes to plate choice, I think that a plate that allows this sort of compression mode is good. There are a lot of different options that you can utilize. So the plates come in large frag and small frag. Large frag plates are 4.5 millimeters, and the small frag plates are 3.5 millimeters. The large fragment plates also come in a broad and narrow version, and we actually chose a more narrow plate in the 4.5 millimeter version for this particular patient. The narrower version of the plate really seems to sit a lot better on the humerus and is very commonly used for treatment of humerus fractures. If you look in the literature, you can see some reports of successful treatment with smaller plates, the 3.5 millimeter plates, and I have seen a couple of instances where the patient's anatomy would have just been overrun by a large fragment plate. There are other different options in terms of utilizing mini fragment or smaller screws when necessary to put smaller fragments together, if that's what you choose. I really, for the most part, choose to tackle the larger fragments and stay away from mini fragment plates if possible, just because a lot of times you may create a construct that's too stiff. If you have these smaller portions, you're better off with a more bridging type technique. So we're using the same kind of plate. We're just not compressing the fracture patterns, the fracture fragments tightly together. We're taking advantage of stress and strain and a different type of bone healing, secondary bone healing, which is good for more comminuted type fractures. This fracture was simple enough that we could put the pieces back together and utilize or depend upon primary bone healing to get things healed up, and that was our goal and our plan. So when you're doing this sort of compression type technique with a plate, you want to ensure that you have enough screws on both sides of the fracture to hold it in place, to give the fracture enough time to heal. So in general, at least 4 screws on each side are recommended when we're fixing humerus fractures to make sure we have appropriate and strong fixation of our fracture. And that's what you see we did here. So if you've done a tricep splitting approach after you have appropriate fixation of your fracture, the closure is relatively simple. You can put a suture layer through the triceps fascia, and then you close the skin with a subcutaneous layer and whatever you choose for the skin itself. In general, no bracing is required after you treat these fractures if you have excellent fixation. I don't tend to put any splint or brace on my patients. I'll give them a sling to wear for comfort, but I don't want to tie up their elbow and give them a stiff elbow or a stiff or a frozen shoulder. So we really don't splint or brace these patients. If I'm worried about the skin, I might put them in a splint for a week and take it off. But I try to minimize any splinting or bracing after fixation of humerus fractures if at all possible. I encourage range of motion of the shoulder and the elbow right away. There's no reason not to limit that. And if this is a patient that is a polytrauma patient or something like that and needs to ambulate with that arm, they can weight bear as tolerated through that particular fracture. It's fixated well enough that we can allow them to weight bear as tolerated and use that arm for mobilization. So I think in general, I've mentioned most of the post-op protocol. Encourage motion. Weight bearing as tolerated is just fine. I don't want patients doing heavy lifting or pushing or pulling, but body weight and below is just fine with these particular injuries. Unless the patient has other risk factors, DVT prophylaxis is not commonly needed or indicated. But if risk factors require that, then DVT prophylaxis can be important. In terms of follow-up and watching for healing, I tend to see the patient first 2 weeks after their injury to make sure that their wound is okay. Again, if I put them in a splint or a brace, I'm going to see them 1 week after surgery to get them out of that and work them towards moving as quickly as we can. And then we don't allow any heavy lifting, so nothing beyond body weight, until we get a healed fracture. One thing I do want to mention is that the humerus can take some time to heal, and so you have to be patient with this particular fracture, and you have to make sure you're watching it to healing. It can be 6 to 12 weeks depending on the patient. I think when we're doing these compression type platings that the dissection required does kind of slow our healing down a little bit. So when I'm treating patients with humerus fractures, I'm always thinking about those other metabolic things that are going to help us with healing. So appropriate nutrition. I always check vitamin D in patients that I'm treating humerus fracture, either operatively or non-operatively, to make sure we're successfully repleting vitamin D to help with healing. So for this particular patient, we have our first follow-up at 2 weeks, and you can see his follow-up x-rays. We have a well-aligned fracture and good placement of our implants. We're going to continue to follow this patient along to healing, and I will provide updates as we go to show the healing of this fracture. And when it heals, I'll, in an update, show you some of the x-rays for this particular patient. So to recap the journal club type articles that we're going to post, I'm going to post some articles about the about the algorithms for observation and treatment of humerus fractures in the setting of a radial nerve palsy, and then I'm also going to post that journal article about the approaches to the humerus. For our poll questions this week, I have 5 questions that I will post on Twitter with hashtag FXConf, hashtag fracture conference. I'm curious to hear what everyone does for initial immobilization of a humerus fracture. Do you guys use a Sarmiento brace right away, or do you put patients in coaptation splints? I'll include a picture of a coaptation splint on the screen here. I think in general that these splints are very hard to put on patients. They're uncomfortable. The patient, for the most part, can't wear a shirt after you put this splint on them. So this can be a really difficult thing to send a patient home in, and I tend to not do it. So I'm curious to see how many of you out there are still using coaptation splints. I'm curious to see how many people use posterior versus anterior approaches to the humerus. I just kind of talked about the posterior approach because that's what we use for this particular patient, but I really like the anterior lateral approach to the humerus instead. And at one point we'll talk about a particular case where I use the anterior lateral approach. I think we'll choose a humerus fracture non-union that I've treated to talk about that at some point here in the future. So I'm curious to see how many people prefer posterior versus anterior approaches, or if it's more of a tailored to the patient approach. If you do a posterior approach, I'm curious to see how many people are still using tricep splitting approaches, or if more people have gone away to the more paratricipital or the triceps sparing approaches. I think they're both good approaches, and I think that understanding both of them for different utilities is important. I'm curious to see how many people use broad versus narrow plates, and I also will probably post with that question I'll include the small fragment, the 3.5 millimeter plates. I'm curious to see if there are many people out there who are using 3.5 millimeter plates for fixation of humerus fractures. And then the last question that I'll ask is what you guys do with weight-bearing status after you fix these fractures. I think that we're being more and more aggressive with weight-bearing after these injuries, and I think that's good and appropriate. And I just want to see how many folks out there are being more aggressive with weight-bearing after humerus fractures. So that's it for today's case, everyone. Thank you for watching. Please remember to subscribe below if you haven't. Also follow on Twitter if you haven't already. That will be my Twitter, RKH_MD, will be down on your bottom left-hand portion of the screen there. We welcome and encourage your comments or questions. I really hope that we can get some feedback and some robust conversations going through these presentations. I'm hoping to continue with one a week of these. This one's a little bit later than I wanted it to be, but I wanted to make sure that we got a good case, and I've been sort of playing with my equipment in terms of cameras and microphones and what I'm using to make sure we're getting a good product out there. So if you've watched and you like or hate, please let me know either or in the comments. If you have any feedback for what you'd like to see, please let me know that as well. And I'll look forward to hearing from you, and I'll look forward to seeing everyone next week for our next fracture conference.